Welcome to the Gastro Girl Podcast. We bring together patients, experts, and health advocates who are all here to help you optimize your health. Here's your host, Jacqueline Gaulin.
Welcome to the Gastro Girl Podcast, where we bring you expert insights, patient stories, and practical strategies to help you navigate digestive health with confidence. I'm your host, Jacqueline Gaulin, and today we're taking a closer look at a critical yet often overlooked aspect of IBS-C, the psychosocial burden and the lengths patients go for relief. Our guest today is Dr. Sarah Ballou, a licensed clinical psychologist with specialized training in cognitive behavioral therapy for adults with chronic illness, anxiety, and stress. She is the director of GI Behavioral Health at Beth Israel Deaconess Medical Center, an assistant professor of medicine at Harvard Medical School, and part of the Institute for Gut-Brain Research, where she leads research on gut-brain connection and behavioral therapies for chronic digestive conditions like IBS, IBD, and celiac disease. Dr. Ballou's research and clinical experience have revealed just what IBS-C patients are willing to give up for symptom relief. And the results? They highlight how deeply this condition affects every aspect of daily life, physically, emotionally, and socially. Today, we'll explore these insights, examine why patients feel driven to make such significant sacrifices, and most importantly, discuss strategies to help them find relief without compromising their quality of life. Whether you're living with IBS-C, IBS, or you're a healthcare provider looking to better understand the patient experience, this conversation is packed with valuable takeaways. So let's get started. This episode is sponsored by Ardelyx. And I just want to remind everyone of Ask Gastro Girl app. This is our AI-powered patient education tool. It's based on our proprietary evidence-based knowledge where you can access answers to your most common GI questions and feel like you have Gastro Girl in your pocket. So if you're confused about what a condition is, you need more information about how to manage your condition, or you're exploring treatment options that you can discuss with your provider, check out the Ask Gastro Girl app. You can download it from the App Store or learn more about it at gastrogirl.com. Thank you so much for joining us today on the Gastro Girl Podcast, Dr. Ballou. Nice to see you again.
Thanks so much for having me.
So first, we're going to start off with helping our listeners understand the role of a GI psychologist. And you're a GI psychologist, and it would be really helpful if you could explain what that means and how what you do differs from what we all may know as a general psychologist, or someone that we would go to if we just had anxiety or we needed help working through issues.
Sure. So a GI psychologist, also sometimes called a gastro psychologist, is a licensed clinical psychologist who specializes in treating patients with chronic digestive conditions. And so we see a range of different GI diagnoses. And what we offer is usually called brain-gut behavioral therapy. So especially when we're treating patients with disorders of gut-brain interactions, such as irritable bowel syndrome, the primary treatment target of brain-gut behavioral therapy is to address the kind of communication between our brains and our GI systems. And doing so, our main goal is to reduce IBS symptoms or improve the symptoms themselves. A secondary goal that we would have in brain-gut behavioral therapies would be to improve stress coping or reduce anxiety, improve mood, but really the primary treatment target is the symptoms. Usually a GI psychologist sees patients for short-term therapy, so between 5 and 12 visits. Very rarely would you see a GI psychologist for like long-term counseling. And that's different from general mental health. So in general mental health, it's really not uncommon that you might see your therapist for years at a time to kind of cope through things that come up in your life, dealing with anxiety. And so this is really one main difference. Also in general mental health, or a general psychologist, of course, their goal is to treat mental health concerns, right? So most patients, if not every patient that's seeing a general psychologist, will have a mental health diagnosis, maybe generalized anxiety, major depression, bipolar disorder. And the difference between, general psychology and GI psychology is that the majority of patients seen in GI psychology have never had a mental health diagnosis, do not have one now, and may not ever have one in the future. But they're coming to a GI psychologist for help with that mind-body connection, or to cope with stress or anxiety specifically related to GI symptoms, even in the absence of other mental health diagnoses.
Dr. Ballou, that's a great explanation, and it's so clear. And I hope our listeners really understand the huge difference. And I want to point out that over the last several years, this field has really evolved. And I know you're one of the early champions of this approach. You and your colleagues that have made great strides in raising the awareness of the role of the GI psychologist on a patient's care team. Could you explain how you collaborate with gastroenterologists and maybe other specialties as a GI
Yeah.
psychologist?
Yeah, I mean, it's a great time to be a GI psychologist now because I think, the gold standard really has been set that, when we're treating especially conditions that are related to dysfunction in the brain-gut axis, that psychology needs to be involved. I would say that, most large academic medical centers at this point have a psychologist that's fully integrated into a GI clinic. And full integration is really how this works best, although there are other models as well. So when a GI psychologist is fully integrated, we're working closely with the whole team. So we're working closely with the gastroenterologist who's making the referral. We work closely with nutritionists when they're part of the team, with pelvic floor physical therapists to make sure that everybody is kind of thinking about the true biopsychosocial conceptualization. We're thinking about the medical foundation of where these symptoms are coming from. We're thinking about the psychological impact of symptoms or any relationship between stress and symptoms, and also kind of what's going on in a patient's social environment so that we can provide this holistic healthcare. This is not always available. So like I said, it's the gold standard, but it's not available in every GI clinic. So other models of, integration, which are kind of like lower level integration, might be a GI psychologist who's working in private practice that takes referrals from a GI clinic and, communicates whenever possible with the referring provider, but isn't part of kind of the core team.
Now, I know we're here to talk about IBS-C and the burden of patients that patients have, but I want to set this up in the right way because I really want to showcase why you're the best person to be talking about this right now. And it's going to all make sense as we move through the episode. So let's talk about who can benefit from working with someone like you, a GI psychologist.
Yeah. So I think any patient who has IBS or a disorder of gut-brain interaction could probably benefit from at least a couple sessions with a GI psychologist to talk about the brain-gut connection and kind of like regulating our nervous systems in order to help to improve symptoms. But not every patient that we see has a disorder of gut-brain interaction. So other patients who have inflammatory bowel disease or celiac disease would also benefit from seeing us to talk about things like, the impact of their symptoms on their quality of life or impact of their symptoms on kind of their ability to function day to day. I would say that any patient who recognizes a relationship between stress and their symptoms in either direction, so symptoms as a source of stress or stress as a trigger for symptoms, would benefit from seeing a GI psychologist. And also any patient who recognizes a tendency to worry about the possibility of having symptoms, to worry about the possible consequences of having symptoms, to have fear that they may not be able to cope with symptoms in specific situations. Those are all things that really can improve with some work with a GI psychologist.
This is so enlightening, and it's so key because years ago we didn't have this. When I was first diagnosed with IBS years ago, I'd never even heard of a GI psychologist, and there was just minimal understanding, evidence-wise, of the gut-brain interaction on all of these symptoms. So, like you said, it's a great time to be a GI psychologist, but it's an even better time, if there is a better time, to be a patient with some of these conditions because there is really a full spectrum of help and care in a multidisciplinary way. And what you do is so key. What steps should a patient take if they're interested, if they're listening to this, like, I think this may benefit me? Do they need a referral? Are there resources that they can tap into? How would they find someone like you?
Yeah. So for those patients who are, I guess, in my opinion, lucky enough to be at a center that has a GI psychologist, it's easy. Just talk to your gastroenterologist, ask them for a referral. There's usually, at least months of a wait list. So get on the wait list and, it usually moves along fairly quickly. If you don't have a gastroenterologist or a primary care physician who is able to make a referral specifically to a GI psychologist, there are a few things you could do. You could look on the Rome Foundation's website. They offer a directory where you can look up, you can put in where do you live, what is your health insurance, and see if there's anyone in your area. I would start there. If you're not able to find anybody near you, then I think the next best thing would be to look on, whichever directory you might choose. I like to use psychologytoday.com to search for therapists. And you can filter to see if there's anybody who specializes in behavioral medicine or health psychology. Even if a therapist, hasn't had the expertise in gastroenterology, if they do have training in working with patients with chronic medical conditions, for example, chronic pain, fibromyalgia, they will probably be able to get up to speed well enough that they can, kind of help you to learn some of the tools to cope and to improve your symptoms. It's not perfect, but I think it's a totally appropriate substitute in the absence of having a GI psychologist available.
So we've had numerous conversations, emails, DMs from patients all over the country, and they all say the same thing. They feel that IBS and IBS-C is not just a physical condition, but an emotional and social burden. Why do you think this is the case?
Well, I think if it were only about how many times a week someone's pooping or not pooping, that really wouldn't be such a big deal, right? It would just be a number in the week, but it's about everything that comes with it. It's about the discomfort, the pain, the bloating, the impact on our schedules. If you're, taking time, trying to have a bowel movement, but not having one, feeling frustrated, right? It's not just about how often somebody's pooping. It's so much more. It's everything that's tied into it. And so I think that's why, right? So, waking up in the morning and maybe having the feeling like if I don't have a bowel movement, I'm going to have a terrible day is a hard way to start your day. And that's how so many of our patients with chronic constipation are starting their days.
Yeah, my grandmother was like that. I've said this on several podcasts. Like I grew up and, I was young. I didn't know what this meant, but if she didn't, if she was constipated, we knew that word, she would just, her whole day would be ruined. She wouldn't be in a good mood. She didn't want to go anywhere. So, and you see her popping laxative. Back then it was Correctol and Senecock and all those things. And, I wish she knew all of these things that we know now. She would have been a good patient for you.
Sounds like it.
Yeah, she was great. But in all seriousness, how do you think IBS-C and IBS-C compare to other chronic illnesses in terms of quality of life impact?
There have been some, there's been research, not necessarily specifically about IBS-C, but comparing quality of life to end-stage renal disease and diabetes, right? And we know that the impact of quality of life of irritable bowel syndrome is significant. It and sometimes is even worse than our patients with end-stage renal disease, for example. So it's not minimal. It really has a wide kind of range depending on who's experiencing the symptoms. Some patients are much more bothered and some patients are not. But the quality of life impact is significant.
Well, this is a great segue to talking about your research. You have an acclaimed research that you've done, and also your clinical experience that has uncovered some really striking insights about what IBS-C patients would sacrifice for symptom relief. And it's still extremely relevant today. And I would appreciate if you could share more about this and some of the most unexpected findings that you've experienced.
Yeah. So this kind of line of research is really important to me. This is actually what I did my dissertation on, was thinking about the day-to-day impact of IBS kind of on our lived experience. And in 2015, the American Gastroenterological Association did a really large survey called the IBS in America study, where they were basically looking at kind of the lived experience with IBS, including impact on day-to-day life and kind of medications taken and satisfaction with treatment. They really asked a lot of, really comprehensive set of questions. And we were able to go back to that database and query the questions that were specific about what are patients avoiding due to their symptoms and kind of like what do they feel they're not able to do. And what we did, and I think this was probably the largest time this has been done, was we compared IBS-C and IBS-D on the questions about kind of day-to-day life. And we found that the patients with IBS-C, well, across the board, patients reported things like, they didn't really want to go places that didn't have bathrooms. They, felt hesitant to socialize, things that we expect from our IBS
Right.
patients. They maybe were doing less activities outside the home, or, more nervous about going outside the home. But what we found specific to IBS-C was that compared to IBS-D, kind of the impact of symptoms was more internalized and related to more kind of private and intimate behaviors, right? So our patients with IBS-C were more likely than IBS-D to report avoiding sexual intercourse. They were more likely to report feeling self-conscious or feeling not normal, not like themselves. They also reported an increased difficulty concentrating in whatever their day-to-day tasks were. And so I don't know that we were necessarily surprised to find these differences. I mean, I think we'd certainly expected to see in the IBS with diarrhea patients that they didn't want to leave the house as often or needed to make sure a bathroom was available. But I think we were, interested to find that the IBS-C experience seemed so kind of private and internal.
Yeah, I guess so. It makes sense. If I've experienced some of those personally, and it is so true. Like you're so hyper fixated on what's going on in your lower abdomen, and it's aggravating, and it's almost demoralizing because you feel like you're not normal, and it's like, why is this happening to me? And we've heard from patients, and some of them are so desperate. We've had other gastroenterologists on. And I remember people just begging me to tell how they could contact this person, or we had a patient who was our doctor. How can I get in contact with him? I mean, it's desperation, and you see that day to day and in all of your research. What does that tell us about really tell us about the emotional and psychological toll of IBS-C on these patients' daily lives?
Yeah. I mean, I think it's a really lonely experience, right? Constipation is so common, but people are really not talking about the toll of it. And so I think, number one, it can feel very isolating to be, maybe in the bathroom for an hour at a time, feeling like I'm trapped here. I can't leave here until I move my bowels, right? And that can be kind of like a lonely and sad moment for a lot of patients. One thing that I have also noticed in my clinical experience, although I haven't seen it described in the literature, is a tendency towards kind of like ritualized behaviors or superstitious behaviors in the bathroom. I have to eat my breakfast at a certain time. I have to work my coffee in at this time. Then I have to do stretches or whatever exercises. And then I go on to the toilet, and then I stay there for 30 minutes. And people can really have a very regimented and bordering kind of on superstition. If I don't do it exactly this way and in exactly this order, I may not have a bowel movement, and that might have consequences, right? And so I think it's not only the emotional toll, but there's also kind of like the cognitive burden of, what time do I have to wake up so I can do my whole ritual? Or, the behavioral piece of it of, oh no, what if I missed a step? What does that mean for me, right? There's a lot of thinking and worrying kind of going on where most people, even people in your own family, might not fully appreciate what you're going through.
Have you noticed a sense of like guilt or shame if they don't do all those things, or they're embarrassed in front of their family or coworkers? They maybe have to miss another day at work because they don't want their coworkers to think they spend too much time in the bathroom. And we live in such a judgmental society. Like every little thing is scrutinized these days. I mean, do
Mhm.
those feelings come into play? Have you seen patients who feel those ways?
Yeah. Of course, I think, shame or kind of embarrassment comes up so often, especially when we're thinking about our bowel movements or, what people might notice about bowel movements. I think more often I see an anxiety, if I don't do it just right and it doesn't work, did I do this to myself? Or, what does that mean for the rest of the day? And kind of thinking about what the potential consequences might be. And, that's a real target of brain gut behavioral therapy, is to say, okay, we want your symptoms to improve. We hope that by doing this therapy, your symptoms are going to improve, but kind of like on the way there, we want to help you to think about the potential consequences of symptoms, or what people truthfully might be thinking about your symptoms, right? In a way that's more balanced and kind of less negative. Or we might want to help you to challenge yourself to say, if I don't do exactly that bathroom ritual, what changes? Or can I actually still move my bowels, to help loosen up some of these beliefs and help to put the patient back in the driver's seat versus kind of along for the ride with constipation.
Yeah, and you mentioned stress and anxiety, and it's almost like this vicious circle because we know that there's this gut-brain interaction. We know that stress has an impact on symptoms, and they could present in either IBS-D or C, what we've learned from talking to our experts such as yourself. And then here we are in this cycle because we're stressed about our stress of not going to the bathroom or going too much. And it's this vicious circle. So how can patients break this cycle?
Yeah. So that's where a GI psychologist kind of comes into play. And, one of the most, widely studied and kind of evidence-based interventions for IBS is cognitive behavioral therapy, which is meant specifically to break that cycle, to help a patient realize, when are they engaging in kind of overly negative thinking? When are they engaging in, worries about the worst case scenario, and how is that helping them, or is it hurting them? And can they start to catch themselves when they're having these kinds of worries, or catch themselves in these negative thoughts, and just slightly change it so that they can move on from it a little bit faster before they get sucked back into that kind of cycle.
That makes such perfect sense. And this brings us to my next question. What are some of the misconceptions about IBS-C that you encounter in clinical practice with your patients? Like, what are some of the things that you're dealing
Yeah.
with?
I hear my patients talk about two things a lot. One is a fear that if they don't have a bowel movement, that they're going to have toxins build up in their body, right? And so there's kind of like that extra pressure on themselves to move their bowels to avoid this. I don't know where this belief comes from, like if they read it somewhere, or if it's just a common thing to think when you're kind of feeling so backed up. But I think that is a misconception that is one that we can kind of let go of, or we can work in therapy if necessary, to kind of like reduce the anxiety about the possibility of toxins in their body from being constipated. Another misconception I have, or I see, that my patients, tell me often, is that they really believe they should be able to move their bowels regularly without the help of any medication. So even if a medication's helping them and they're having some relief, they're then kind of piling on and saying, but I shouldn't need it. I should be able to do this without the medication. And that's one that, I kind of want to intervene on quickly with my patients, to help them to kind of accept the relief when they can get it, or to unpack, what's behind that belief about should be, needing to be able to do it without medication.
And that's, I was going to ask this later, but I think this is important to ask now. It's not one or the other, right? It's not going down the path, working with a GI psychologist and not being on a treatment regimen that your gastroenterologist recommended. Can you explain a little bit why it's important to maybe have this multidisciplinary, and there could be dietary interventions as well. Like, how does that all work together, and why is that important to have this
Yeah.
multidisciplinary approach to a patient's treatment plan?
Brain gut behavioral therapy shouldn't be meant to replace medication, just like nutrition intervention shouldn't be meant to, replace medical treatment. So I think, we want all of the pieces to be working together so that we can really get things moving, literally, in the case of constipation. Most of the patients that I see, have gone through lots of different treatments. A lot of them I see come to me, and a lot of the treatments haven't worked very well for them. I think there are survey studies, or there's literature about it, but I think it's about half of the patients who receive medical treatment for irritable bowel syndrome kind of after 6 months report that they're not feeling adequately better. And those are the patients who really, I think, could benefit from pulling in some of the other multidisciplinary people. So brain gut behavioral therapy is never meant to substitute for medical treatment. But surely sometimes there are patients who say, I'd really rather not try a prescription drug. And then we could, add in a CBT and see if that helps before we go to the prescription medications.
And I think there, and correct me if I'm wrong, but I think there could also be at play an inherent fear or anxiety around taking medication. We start reading everything, and I know I'm guilty of that. And I get nervous about taking things. And do you find that that's also, and that's why a GI psychologist could really help have a patient, relieve some of that so that they can really see if that treatment protocol could have a chance at working.
Yeah. I mean, we live in a time when there's a lot of information at our fingertips. And, the internet can be a scary place, but the internet also has really valuable information. And our patients often know how to consume it, but it still can be overwhelming, even if they're consuming accurate, good information, right? So I think it is nice, even if they've, been on PubMed or they've been on a website that we know is not, giving them inaccurate information, it is good to be able to have somebody where you maybe have a full 45 minutes to sit and say, these are my fears. This is what I read. Let's talk it through. Let's think about it kind of in a practical way so that they can make decisions that are based on information versus on their anxiety or fear.
No, you're absolutely right. It makes total sense. And another thing that patients have told us, and I'm sure you've heard this too, is patients often feel dismissed, right? They often feel dismissed or unheard by their provider. And I guess there's a two-part question to this. What steps can patients take to advocate for themselves? And on the other hand, what can gastroenterologists and even primary care providers do to better address the mental and emotional toll of IBS-C in their treatment approach to these patients?
I'm going to start with the second question and go back to the first question, because I think the most important thing, and what I've been giving talks about this and writing papers about this is, I hope that everybody who's treating patients who have IBS is kind of figuring out how to do some kind of psychosocial assessment. And it doesn't need to be a battery of questionnaires. And it doesn't need to be a long or, comprehensive mental health assessment. But I want every clinician who has a patient in front of them with IBS to get used to asking questions like, how has this affected your quality of life? What is the relationship between stress and your symptoms, right? And the reason I want them to do that is, number one, I want the physicians to start to work this into their conceptualization of how the symptoms are, kind of affecting this patient and maybe what the cycle is of stress and symptoms. But I also want patients to have the opportunity to talk about it, because this is the first opportunity for a little bit of brain gut behavioral therapy before a referral to mental health providers ever been made, right? Just the act of saying my physician knows and understands and is interested in the impact of my symptoms on my quality of life already is therapy, right? Talking about it or having the chance to talk to an expert about it is really important. So I want clinicians to be able to do that and be willing to do it. It shouldn't take too much time out of the clinical visit. I'm thinking it'll take just a few minutes, maybe less, right? But I think the value is huge. For patients who feel like their physician is not asking those questions, or who feel like their physician is not hearing their report of, the impact of quality of life, I think there's a few options, right? If you're in a place where you have the luxury of having multiple providers to choose from, you could try to find another provider if you're really not feeling like this, kind of is getting through. If you don't have that option, or if you don't want to do that, you could also try to talk to your clinician about the research. You could say, I've looked into the brain gut axis, and I understand that there's a relationship between stress and symptoms. And I want to talk more about that, or these symptoms are really affecting my quality of life. Sometimes when you present, I know that there's an evidence basis for this. I want to talk about the research that's been done. It gives the clinician kind of a place to go learn and then come back to you to talk about. So you can try to nudge them in that direction to have this discussion.
No, that's great advice, and it's so key. And I'm glad you framed it in such a way that it's a dual approach. It's not just the patient's responsibility, and it's not just the providers. It's sort of a synergistic approach. And I just want to ask, like, a quick tip. Like, sometimes patients, myself included, are in the moment, our symptoms are horrible, but then by the time we may have our appointment with our provider, we've kind of just pushed it to the side. Like, what is your recommendation to really empower the patient to either document or to understand that intensity and be able to communicate it, even if it's a month or 2 months or 3 months later, to the provider? Because sometimes our symptoms are like, they're waves, they come in waves.
Right. Right. Yeah. I mean, I think many times patients, when they're sitting in front of their gastroenterologist or their primary care physician, I think we kind of want to be okay. We want to show them that we're okay, or show them that we're being a good patient and we've done all the things and look, we're getting better, but then we go home and we're miserable. Right. And so I think, trying to be aware of that, I guess, tendency to want to perform in the medical encounter, but to really say, like, even though I'm feeling okay today, like, I want to give you the full picture of how this is affecting me. Or, even though it's been a good week, like, I really want to stress that the 2 weeks before that were really bad, and I missed 2 days of work, or I felt like I wasn't able to participate fully in, interacting with my family, or whatever it may be. So I think you don't have to be in agonizing pain. You don't have to be really, really, really sick in the day of the visit in order for a physician to be interested in what your experience has been. And I think we need our patients to feel empowered to kind of talk about what their experience with symptoms have been.
You're right. We don't want to, we want to be okay in front of the doctor. Like, I'm a good patient but we forget what happened the last 3 weeks. And
Mm-hmm.
so that's so great. Now, before we close out, I want to just sum up and see if we could get you to give us some strategies for symptom management without the sacrifices that you've seen in your research and in your clinical practice. Many patients feel like they have to give up things they love, including family time, being able to take trips, being able to travel for work, or even career opportunities to manage their IBS-C. Like, what are some ways they can regain control of their lives while managing symptoms?
Yeah. So I think I would just start by taking an inventory of really what have you sacrificed, because most patients don't sacrifice it all at once, right? First, they take out hiking, and then they take out, whatever else it is that they liked to do, right? And slowly but surely, they start to remove things from their lives that they used to enjoy, and now they're not doing anymore, but sometimes without even realizing how many things are gone. And so I think the first thing I would do is take a look at what are you not doing anymore that you used to do and enjoy, and actually, is it helping you, right? Or are you just as constipated as you were before? The only thing worse than being, chronically constipated, kind of when we're thinking about like chronic GI symptoms, is being chronically constipated and also not doing anything that you enjoy, right? So sometimes what we need to do, it's not realistic to add it all back in, right? Sometimes you've taken them away for really good reasons, but sometimes what we need to do is think like, okay, could we test it? Could we modify it in a way so we're moving a little bit back towards something that you used to like doing? So from a behavioral perspective, I think like adding things back in is huge. It's really important, and it's going to be hard. It's going to be scary, but the payoff can be incredibly, strong. The other thing, one of the simplest tools we have in brain gut behavioral therapy, but that can be also sometimes one of the most powerful tools, is learning to turn on our relaxation response, the rest and digest response. Part of the dysfunction between the brain and the gut communication has to do with like turning on that fight or flight system too much. So engaging in things like daily meditation, even if it's 5 minutes a day, deep breathing for a few minutes a day, progressive muscle relaxation, downloading, an app like Insight Timer is a free one that has great guided relaxation exercises. That is such a simple thing to do that if you do it daily and you commit to it long term, really can have an impact on your mental health, on your physical health, and on your GI health.
That's great. Now, key takeaways. If there's one takeaway you'd like IBS-C patients to remember from this conversation, what would it be?
I think it would be that you're not alone. About 12% of people worldwide, not just patients, like everybody in the world, about 12% have some kind of chronic constipation. So if you're, statistically speaking, if you're in a room with 100 people, there's probably about 10 other people, 10 or 11 other people who know what you're going through, right? But you might not ever know it. So the impact can be, so significant, but also so kind of like private and personal. It's easy to feel like nobody gets it. People get it, right? And there are treatments that can help you. So if you think you would benefit from a GI psychologist or a meeting with a mental health provider, ask for a referral.
And for healthcare providers, we got one for you too. What's one key message, Dr. Ballou, you'd want your colleagues to hear about in supporting IBS-C patients more effectively?
Ask questions. Ask how constipation is affecting their quality of life. Of course, focus on getting the bowels moving, but don't focus only on that. Ask, what is it like to have this? How has this impacted your day-to-day life? How has this impacted your mood? What is the relationship between stress and symptoms? Really important information is going to come out. It's probably coming out anyways, but it just might not be kind of making it into your conceptualization. So for my GI colleagues, I would just say, work in the psychosocial assessment into your interviews with patients. It will pay off, and there will be really valuable information.
Well, Dr. Ballou, this has been such an insightful and meaningful conversation. Thank you so much for shedding light on the emotional and psychological burden of IBS-C and sharing such practical strategies that can truly help patients navigate their symptoms with confidence and control. To our listeners, if today's discussion resonated with you, know that you're not alone. As Dr. Ballou said so eloquently, there are behavioral health strategies and expert support available to help you manage your symptoms and seriously improve your quality of life. If you'd like to learn more about Dr. Ballou's work or explore GI behavioral therapy or gut-brain therapy, we'll have resources linked in the show notes. And as always, if you found this episode helpful, subscribe, leave a review, and share it with someone who might benefit. And your support helps us bring more expert insights and patient-centered conversations to the Gastro Girl community. Thank you for listening. And until next time, take care and be kind to yourself and others.
Thank you for listening to the Gastro Girl Podcast. For more information and resources, please visit gastrogirl.com. Do you have a question for Gastro Girl? Please email podcast@gastrogirl.com. The information, opinions, and recommendations presented in the Gastro Girl Podcast are not a substitute for medical advice from your healthcare professional. Please consult a licensed clinician in your state regarding all matters related to your health.